Hello, I'm Dr. Scott McMeekin, a gynecologic oncologist in Oklahoma City, Oklahoma. I've been asked to speak with you today about I have endometrial cancer, I've had surgery, what do I do now? We'll be talking about adjuvant therapy for early stage endometrial cancer. Well, what is cancer? Normal cells behave. They have an off and on switch. They have stop and go lights. They grow, they stop, they grow, they die, and the body has the ability to replenish new cells. It is orderly and very precise. These normal cells can undergo genetic changes. We see this with aging, due to exposure to agents or toxins, due to a predisposition inherited from family members, or due to things that we don't understand yet. And these normal cells take on new properties. They become a cancer. Cancers have uncontrolled growth. They can form a mass or a tumor. They can locally grow or destroy normal tissue that surrounds it. It can spread to lymph nodes or can spread to other parts of the body by way of the bloodstream. Well, what is endometrial cancer? The uterus is a muscular organ that makes childbirth possible. We hear of this as the womb. The uterus has a central cavity that is lined by a layer of cells called the endometrium. When the endometrium undergoes a cancerous change, we call that an endometrial cancer. Now, a variety of cancers can develop from different cell types within the uterus, like the muscle or support tissues, but cancers arising from the endometrium are the most common. Well, what does an endometrial cancer do? Endometrial cancers may or may not spread outside of the uterus. Inside of the uterus, the cancer can grow into the uterine wall, can extend into small lymphatic channels in the uterus. It can grow to the tip of the uterus or the cervix. Outside of the uterus, a cancer can spread to the ovaries or fallopian tubes, to lymph nodes in the pelvis or abdomen, to the belly cavity, or to distant sites like the lung or inside the liver. Doctors refer to stage as a description of the extent of cancer spread. Most patients with endometrial cancer have stage 1 disease. That is, the cancer is confined to the uterus. Well, how do endometrial cancers behave? Doctors do not have a perfect way of determining if a cancer has spread or not. In most cases, there is no apparent spread. That is, we don't see anything with our eyes, feel anything on examination, and X-ray studies look normal. But unrecognized spread can occur and is a reason why a cancer may return at a later time, even though it didn't look like it had spread. Now, the chance that a cancer might have spread or can come back is estimated based on a variety of factors. These factors include your age, how deep the cancer grew or invaded into the uterine wall, the tumor grade, how it looks under the microscope, something we call the histology, and if it has spread outside of the uterus, that is the stage. Now, there's a distinction between grade and stage. Grade describes how normal or abnormal the cancer cells appear. Cells that look pretty normal to a normal endometrial cell are called grade 1. Cells that look pretty abnormal are called grade 3, and grade 2 are kind of in the middle. Now, stage refers to the extent that the cancer has spread, but grade refers to the appearance of the cells themselves. These have important implications in your treatment. Now, this discussion is for women who have had a surgery and there is no clear evidence that the cancer has spread outside of the body. That's good news, but not the whole story. Your doctor will talk with you about what features your endometrial cancer has following hysterectomy. We tend to group patients by their risk of the cancer returning. High risk usually means that the cancer has spread outside of the uterus. Some form of treatment after surgery will usually be recommended. Intermediate risk is there is no evidence of the cancer spreading that we can see or feel, but you have certain features that raise the possibility that it may come back when treated with surgery alone. Treatment may be considered to reduce the risk of cancer eventually coming back. This is what we mean by adjuvant therapy. Now, there are a variety of treatment options that we will discuss. Low risk is another category. There is no evidence that cancer is spread that we can see or feel, and you have no features that suggest a possibility that the cancer may come back after surgery. Most patients in this category receive no additional treatment other than surgery. Well, how do you decide what to do? In general, treatments are used to reduce the chance that a cancer will come back, better than what would have happened if we didn't use any treatment. And the system's not perfect. Some patients with intermediate risk get treated, still have the cancer return. Some patients get no additional treatment and the cancer never comes back. Occasionally, a patient with low-risk features will have the cancer return. Research studies help provide the information that allows doctors to counsel patients as to their risk and what benefit any therapy may offer. You and your doctor will discuss the risks and benefits of using treatments after surgery and which option is best for you and why. Your doctor can use information on your general health, age, features from the hysterectomy to estimate that the chance the cancer may come back without treatment, and will help you to try to understand how various treatments may try to reduce the chances that the cancer may come back. Well, what does it mean to have a cancer come back? Well, endometrial cancers may never come back. We talk about this as being a cure in the sense that the cancer never comes back during your lifetime. The cancer may come back in the upper part of the vagina, called the vaginal cuff, in the pelvis, in the abdomen, in the lung, the liver, the bone. We call those distant metastases. Some patients have cancers that come back at several places at once. Others can have it come back in one place, then another over time. Now, the chance that the cancer can come back is related to risk factors that you may or may not have. Some risk factors lead to the cancer coming back locally, like in the vagina or pelvis. Others are associated with the cancer coming back at more distant sites, like the lung or liver. By understanding where these cancers may come back, if they do, treatments can be used to reduce the chance that the cancers come back in that area. So after surgery, what are my treatment options? Well, one treatment option is surveillance. That is doing surgery and nothing else but keeping an eye on you. Your doctor can help make an estimation of the chance or risk that the cancer may return after having surgery alone. You will be asked to consider what that risk is and what steps may be done now after surgery to reduce that risk. Some patients, after weighing the risks and benefits of treatments, elect to do no treatment and see their doctor at regular intervals. Surveillance involves seeing you at regular intervals, usually every 3 to 6 months, to discuss how you're feeling, to perform an examination, including a pelvic exam, and based on these factors, sometimes doing additional tests like X-ray studies, CAT scans, or blood tests. If you're doing well, you'll be asked to return for another visit. If the cancer returns, then the doctor will discuss options to treat that at that time. Some patients view the chance that the cancer may return as being too high, and they elect to do treatments which try to reduce the risk that the cancer comes back. These include radiation therapy and chemotherapy. Radiation is energy directed to an area of the body to destroy cancer cells. It's administered by a specialist, a radiation oncologist. Vaginal radiation, also called vaginal cuff brachytherapy, uses an apparatus similar to the size of a speculum that's used for doing a routine pap smear that is introduced into the vagina. The treatment starts some 4 to 6 weeks after surgery. Usually 3 to 5 treatments are delivered over a 2-week time period, and these are done as an outpatient, that is, you come in and go home on the same day. Radiation treatment time only takes about 5 minutes, but the planning, setting everything up, runs about 2 hours, and the doctors use monitored sedation to keep you comfortable. This is a very effective treatment at reducing the risk that the cancer recurs in the upper portion of the vagina. That is the most common site of recurrence we see. Pelvic radiation is another option and has largely been the standard for which has been used historically. You lie on a table and a machine delivers radiation energy to the lower abdomen and pelvis. This starts some 4 to 6 weeks after surgery, and usually 25 to 28 treatments are delivered as an outpatient, given Monday through Friday, over about 5 to 6 weeks. No anesthesia is required. It takes about 10 minutes per treatment, and there are several techniques available that your radiation oncologist will discuss with you. Some patients receive both vaginal and pelvic radiation. This treatment is very effective at treating the upper part of the vagina as well as surrounding support tissues to the uterus and to the draining lymph node basins. Chemotherapy is another option. It's the use of specialized drugs that are designed to damage, destroy, or control cancer cells. The drugs take advantage of certain properties that cancer cells have, and it's a systemic therapy. That is, it works from head to toe. It doesn't just work in one area of the body. Chemotherapy agents are usually administered by vein, called IV for intravenous administration. There are several terms that we talk about in chemotherapy that can be confusing. The regimen is the cocktail, that combination of drugs that are used. Certain regimens work better for certain cancers, and your doctor will discuss what is considered the best regimen for endometrial cancer. The drugs are given at a dose. That's the amount of drug that's based on your age, weight, kidney, and liver function. The schedule is the timing of when the drugs are given, and usually this is every 3 weeks. Each treatment administration is called a cycle, and somewhere between 3 to 8 cycles have been used in endometrial cancer patients. Chemotherapy has been studied in many patients with endometrial cancer. The most common use that we have seen is in patients whose cancers are widely spread at diagnosis, or if the cancer comes back after initial treatments. Increasingly, it has also been studied in patients like you with earlier stage disease who have certain risk factors. Chemotherapy is often given in combination with some form of radiation therapy, either vaginal or pelvic radiation, or it can be given alone without any radiation. Your doctor will discuss with you whether chemotherapy is appropriate for your treatment, and if it is, what drugs will be used, how will it be given, including the dose, schedule, duration, and the use of radiation. Well, what to expect? During any radiation or chemotherapy use, your doctor will monitor you closely to make sure that the side effects are tolerable and the therapy is helping you. This includes seeing you at regular visits, talking with you about your side effects or concerns you have, and doing examination. Laboratory tests to monitor your blood counts and kidney and liver function will also be performed. Side effects from therapies can either be acute, that is, while you are receiving the treatments, or chronic, those that occur after all the treatments have been done and you've recovered. Your doctor will outline possible side effects that have been seen with your treatment. And not all patients have all side effects, and not all side effects are severe. Your doctor and treatment team will outline several steps that are used to control side effects like nausea or diarrhea. Please share your concerns or any side effects you experience so treatments can be modified or steps used to improve how well you tolerate the treatment. The goal is to make the treatments as tolerable and safe as possible and to have you complete the treatments in the prescribed time period. After the therapy is over, congratulations. You are now one of millions of cancer survivors in the world. Your family, friends, and support group and doctors and nurses are proud of you and your strength. There may have been times when you weren't sure you would get through all of the treatments, but you did. You will now need to have regular checkups or surveillance visits to make sure you have recovered from any effects of therapies, from surgery, radiation, or chemotherapy, to monitor and manage any residual side effects, and to make sure that the cancer does not return. If there are changes as to how you are doing, your doctor will discuss what steps will need to be done to evaluate them.